Hello everybody, this is our second lecture and it will be about inflammatory disease of maxillo-facial area. We will talk about periodontitis, periostitis, abscess, phlegmons and osteomyelitis of lower jaws, of mandible and maxilla. About its etiology, pathogenesis, diagnostic clinics, treatment, prevention and emergency help. So, first of all, I'm sorry. As you know, my name is Maxim Bukov and I work on chair of maxillo-facial surgery in the Kyrgyz Medical States Academy. So, first of all, let's give definition to inflammation. Inflammation is a part of complex biological response of body tissue to harmful stimuli such as pathogens, damaged cells or irritants, and is protective response involving immune cells, blood vessels and molecular mediators. The function of inflammation is to eliminate the initial cause of cell injury, clear out the necrotic cells and tissue damaged from the original insult and inflammatory process and initiate tissue repair. Where uh, classical classical cardinal signs of inflammation. So um, heat, pain, redness, swelling, and loss of function. As you know, color, dullor, tumor, uh, and lost function. Okay. So, inflammation is a localized reaction of vascular in the development of an exudate rich in proteins and cells. This reaction is protective and aims at limiting or eliminating the irritants with various produce while the mechanism of tissue repair is triggered. Depending on the duration and severity, inflammation is distinguished as acute, subacute, or chronic. Acute inflammation is characterized by rapid progression and is associated with typical signs and symptoms. If it does not regress completely, it may become subacute or chronic. Subacute inflammation. It's considered a transition phase between acute and chronic inflammation. And the chronic inflammation, this procedure presents a prolonged time frame with slight typical symptoms and is characterized mainly by the development of connective tissue. The natural progression of inflammation is distinguished into various phases. Initially, vascular reaction with exudate are observed, and when the cellular factors are triggered, exudative or cellular phase. But inflammation finally resolves with destroyed tissue repair. On the other hand, chronic inflammation is characterized by factors of reparation and healing. Wherefore, while acute inflammation is exudative, chronic inflammation is productive. Um, Understanding this difference between these types of inflammation is important for treatment. Uh, Depending on localization of site of entry for microorganism can be distinguished infection inflammatory process. Why we need such classification? Because where different way of entrance means different types of microorganisms. From this list, most dangerous or most pathogenic will be odontogenic infection agent. As in proverb for head is for arm, you can make same some prognosis during treatment with basic on type of infection. Active other or odontogenic inflammatory diseases are microorganisms which actually are included in composition or permanent oral cavity microflora. Staphylococcus, Streptococcus, Enterococcus, Diplococci, gram-positive and gram-negative cocci. According to the data of different authors, even on mine data, where microflora of odontogenic pockets infection most commonly is prevalent by Staphylococcus. Usually it's Staphylococcus aureus. When nascent probably of infection, inflammatory process depends largely on the stage of microorganism immunological reactivity. As you know, reaction can be hypo or hyporeactive, and it can be normal reaction. Let's see what we call odontogenic inflammatory disease. The term odontogenic inflammatory disease is collective. It includes a variety of enough edgy form of diseases in clinical concept. Periodontitis, periostitis, osteomyelitis, apostasis and phlegmons, lymphadenitis, odontogenic geniarthritis. Periostitis. Periostitis is inflammation of periosteum. It's a dense membrane composed of fibrous connective tissue that closely wraps all bones. It invests all bones, except the bone of articulating surface and joint which are covered by synovial membranes. And it can be acute, periostitis can be acute and chronic. Acute periostitis. Acute periostitis, as you can see on picture, this is maxilla periostitis. Maxilla periostitis, most of all, it's usually about, we can talk about 75% of cause. Develops due to recrudescence of a chronic inflammatory process in periodont. Its consequence in bone resorption during the chronic periodontitis, the infection from the periodont tissue easily penetrates to periosteum. Conservative treatment of a tooth also can be complicated by periosteum inflammation. The disease also development after the tooth extraction surgery when it's performed traumatic with the affection of the tooth tissue and gingiva. In the case of incomplete tooth extraction concerning acute or aggravated chronic periodontitis. Clinical aspects of this disease depends from the patient's body responsiveness, type of inflammatory reaction, infection virulence, and localization of inflammatory process. In this period, the well-being deteriorate, rise asthenia, distortion, the body temperature arise, appear the headache, disappear appetite, sleep disturbance, pain sense in the tooth region, irritating, temporal fossa, eye, neck. In the future, the pain intensely fall. In the periosteum appears edema or perignatic soft tissue. Arising bullation change face configuration. Regional lymph glands increase and become more painful. Difficult and painful opening of the mouth appears as a result of inflammatory contracture. Masticatory and wing muscles occur not so often. during the inflammatory process in the region of big root teeth or mandibular bone. What inside the mouth cavity appears hyperemia and edema of mucous transitory fold and adjunct locus of a check through some teeth. The mouth mucus breaks out by the accretion. The transitory fold is flattering. A big bulging superostal abscess appears when the process comes to suppurative form and the exudation accumulates under periosteum of alveolar bone along the transitory fold. When we examine the tooth serving as a source of infection, often is established that its cavity and root channels are filled by necrotic tissue, etiology. Uh, in some cases, where a deep pathological dental pocket. In this period, the pain reaction during the tooth percussion is not pronounced and sometimes is absent. During X-ray study of X-ray examination of the alveolar bone and maxilla body changes specified to acute periodontitis is not emerge. Usually the body temperature during the periodontitis is within 37 and 8. During the blood examination, the period of resistance development is registered augmentation of leukocyte. uh, let's talk about treatment or differential diagnosis. Okay, so acute purulent periodontitis should be differentiated from the acute periodontitis, osteomyelitis, apostem and phlegmons and lymphadenitis. Sometimes periodontitis is mistaken for inflation of sublingual and submandibular glands and weight duct. Treatment. Main remedial measures during the acute purulent periodontitis consist in surgical resection of inflammatory nidus and creation of free outflow formed exudate. More often, it's applied local anesthesia, conduction and infiltrated anesthesia. Insertion of anesthesia solution in the periosteum can be painful. That's why during the infiltration anesthesia, anesthetic is inserted in the sound tissue and the border with infiltrate. Decision during periodontitis make a section of mucus and periosteum through the transitory fold and lay 2 maybe 3 centimeter to all tissue depth till the bone. For free outflow of exudate and prevention of part agglutination in the wound is increased on first 2 days thin drainage, which is fabricated from surgical gloves of polyethylene pellicle. During the decision with periosteum apostasis placed hard place dissect moderate portion of soft tissue from the abscess side if it's localized on palate. So after surgical intervention for speedy resorption of inflammatory infiltrate, it's placed on moisturizing by warm solution of potassium permanganate uh, and you give painkiller and antimicrobial medicine. Well, chronic form of periostitis develops seldom. Predominantly appears in children with age of 9, 13 years and young people. Uh, Not frequently chronic periostitis proceed without pronounced symptomology. Um, The reason of chronic periostitis and chronic osteitis more often is odontogenic infection. Such patients have soft pains in the maxilla, little bullation of perignatic tissue, sometimes can be raised body temperature. In the alveolar bone region appears limited, dense, a bit painful infiltrate. Mucosa seal with infiltrate and appears insignificant hyperemia. Patients do not observe development disease, that's why do not address the doctor. The treatment of a chronic periodontitis has its peculiar. The treatment begins from elimination of a cause, which provides pathological process. Osteomyelitis. Under the term of osteomyelitis, it's understood not only the inflammatory process in bone marrow, but also in all structural parts of a bone and its surrounding its soft tissue. Osteomyelitis represent infection necrotic process which develops in the bone and its surrounding tissue under the influence of aggressive factor of physiological, chemical, or biological nature against the preliminary sensibilization and neurohumeral dislocation. Osteomyelitis can be odontogenic, traumatic, toxic, hematogenic, and specific. There are distinguished three phases or three periods of disease course: acute, subacute, and chronic. Depending on the spread process, the osteomyelitis can be circumscribed and diffuse. It can be localized and diffuse. During the localized or circumscribed osteomyelitis, the pathological process is localized in the region of 2-3 tooth periodontium. Diffuse osteomyelitis is characterized by total affection of half or all maxilla. Let's see acute phase of osteomyelitis. In the acute phase of disease, in the beginning, patient complain of pain in the region of one tooth, which is sourced in infection. However, soon is joined signs of periodont and other neoablative inflammation. The pain increase become tearing, irradiate or divarication or trifacial nerves in eye socket, temporal region, and ear. One of the typical complaints during the osteomyelitis is disturbance in interfacial sensitivity on the lower lips red border. We call it Vincent syndrome. Mouth threshold mucus with chin in the relevant parts, numbs, make one feel creepy. In case of purular inflammatory process in the soft tissue development, where pain moves to outside of the maxilla, appears to complaint typic where perignatic phlegmons, swelling, maxillar contraction, and pain during the deglution mastification. Um, Particularly permanence, it's observed headache, general weakness, rise of body temperature, appetites and sleep disturbance. Patient are pale, the pulse is rapid and some cause arithmetic. In the region of affected, jaw appears infiltration and edema of soft tissue. It fits well from the mouth. Causal tooth begins is mobile, but the future become impaired. But the power become impaired. Um, its percussion is painful. Gum and transitory fault tooth region involved in pure inflammatory process are eodymic and hyperemic, where palpation is sharply painful. In certain cases appear subgums abscess during the penetration of this purulence in cell surface appear abscess and phlegmons in periodontic tissue. In this case appear the infiltration of a tooth, dense consistence and hyperemia of skin integumentals. Muris infiltrate appears pronounced collateral edema in soft tissue, a reflection of inflammatory reaction. Stimulates also can be lymphadenitis. What we can see in general, body temperature rise till 39-40 Celsius. It's assumed the acute phase of osteomyelitis is attended by neutrocytosis with appearance of new form of neutrophilic leukocytes. In hard case, it's be observed necrocytosis till 17. Acute phase of osteomyelitis is characterized more easy course, shortened, and disease duration on maxilla than on mandible. Acute phase of odontogenic osteomyelitis should be differentiated from following disease: acute periodontitis, acute purulent periostitis, isolating inflammatory process of face soft tissue, abscess, phlegmons, and from the cyst of maxillo-facial region. Odontogenic cyst, dermatoid cyst, epidermoid cyst, different cysts, different, I'd like to say tumors, different tumors. If we left acute osteomyelitis untreated, it became to subacute and chronical phase, chronical osteomyelitis. So let's talk about subacute phase. Osteomyelitis subacute phase is short-term, but often it's lasted about 2 weeks. Subacute phase of osteomyelitis is characterized by stabilization of inflammatory process. Operative wounds are cleaned from the necrotic tissue, granulate, and decreased flow of pus and edema. Teeth located in a region of inflammatory nodus became more flexible, more mobility. Typical symptoms of osteomyelitis acute phase is improved to general states of the patient. Disappear weakness, become normal sleep and appetite, descend body temperature, significantly diminished leukocytes and erythrocyte sedimentation rate. The chronic osteomyelitis phase is very prolonged. Pains in the maxilla, in the region of jaw, come down. Diminished the infiltration of soft tissue in the section localized often skin parts of mouth mucosa appears fistulas from which is effused pus. The tearing away of the sequestrum is accompanied by the appearance of granulation and fistulous phase. In the region of osteomyelitis nodus, with jaw is thickened, teeth are usually mobility. Treatment of osteomyelitis. It's must be extraction of a causative tooth in the incidence of acute odontogenic osteomyelitis is basic and obligatory type of therapy of this disease. Alongside with antibacterial, desensitive, and disintoxication medication are used anticoagulants, fibrinolytic, and sedative medication. Mercurial interactive neighboring with causative should be ligated or splinted. For organism desensibilization and reduction of vessels wall penetratively, it's use 10% calcium chloride, antihistaminic medicine, suprastin, dimidrol, diphenylhydramine. It was about chronic. It was about acute osteomyelitis. The chronic phase of osteomyelitis is aggravation cause of inflammatory process is continued antibacterial anti-inflammatory treatment, and it's execute sequestrectomy, operation sequestrectomy. Sequesters on the jaw usually are extracted at 3 weeks from the beginning of the disease. Medical treatment, disintoxication, you can use Ringer solution. Disintoxication is usually appointed in the acute phase of osteomyelitis to remove the intoxication. Solution of disintoxication already said, suprastin, dimidrol, Ringer solution. Antibiotic therapy is appointed for all phases of osteomyelitis. Usually we use lincomycin, kanamycin, because this antibiotic accumulate in bone tissue, and also if you need, you use a painkiller, yes, analgesic medication. We will start now talk about a very big part of inflammation disease, odontogenic abscesses and phlegmons. So we will give definition. Yes, abscess, it's a collection of pus that has built up within the tissue of the body, and phlegmons is a spreading diffuse inflammatory process with formation of purulent exudate. So abscess, it's localized process, and phlegmons, it's a spreading diffuse inflammation. Depending of anatomic topographical localization, odontogenic abscess and phlegmons can be divided into 4 groups. Tissue abscess and phlegmons which adjoin to upper maxilla. It can be superficial and deep. Superficial, it's suborbital buccal zygomatic region, deep subtemporal pterygopalatinal fossa, and secondary, it's temporal region and eye socket region. Also, phlegmons and abscess can be adjoined to lower mandible. It also can be superficial, deep, and secondary. Superficial, it's submandibular, submental triangle. Deep, it's pterygomandibular, peripharyngeal, sublingual spaces. And secondary, it's retromandibular region, frontal region, and neck spaces. Phlegmons and abscess of tongue, and widespread phlegmons or face and neck. Let me show you tablets about I will send it to your groups, and you have to check it and learn the name of phlegmons, the anatomical borders, the causal thieves, the meaning symptoms, and surgical approach to drainage with abscess or phlegmons. So it's will take several times. I think it will be better to just send it in your group to you, learn it, and after I will check it on the classes. Okay. So now we will talk about principles of treatment. Fundamental principles of treatment of infection. So first of all, you have to take a detailed medical history from the patient. You have to you have to ask him when he start to disease, when he start to ill, when he feel bad, which symptoms he have, which tooth he thinks it can be cause of inflammation. Take detailed history from patient. Drainage web pass when its presence in tissue is established. This is achieved by the way of root channel with the intraoral incision, with the extraoral incision, as you can see on picture, and for the alveolus of extracted tooth. Without evacuation of pus, with administration of antibiotics alone, the infection will not resolve. So, what you have to do before incision? You have to plan your incision. You have to not injure with duct and of salivary gland and large vessels and nerves. Sufficient drainage is allowed where incision is performed superficially at the lowest point of accumulation of pus to avoid pain and facilitate evacuation of pus under gravitation. Where incision is not performed in areas that are noticeable for aesthetic reasons. It's a face, you have to aim it. If possible, if it's performed intraorally. So if it's possible, yes. Sometimes it's not possible. Incision and drainage of the abscess should be performed at the appropriate time. This is when the pus has accumulated in the soft tissue and fluctuate during palpation. That is when pressed between the thumb and middle finger, and you feel you have a feeling like a wave. Yes, you feel a liquid wave. We call it fluctuation. Drainage of the abscess is initially performed with a hemostat, which inserted into the cavity of the abscess with clotted beaks and used to gently explode the cavity with open beaks. and is withdrawn again with open bit. At the same time, as a blunt dissection is being performed, the soft tissue of the region are gently massaged to facilitate evacuation of pus. Placement of rubber drain inside the cavity and stabilization with a suture or one lips of incision, aiming to keep the incision open for continuous drainage of newly accumulated pus. Removal of a responsible tooth as soon as possible to ensure immediate drainage of inflammatory material and elimination of a site of infection. Extraction is avoided if the tooth can be preserved, or if it's increased risk of serious complication in case when removal of a tooth is extremely difficult. Administration of antibiotics when swelling is generally diffuse and spreading, and especially if there is a fever presence and infection spread to facial spaces, regardless or when it's indicated to presence of pus. Antibiotic therapy is usually empiric, given the fact that it takes time to obtain a result from a culture sample, because the microorganism isolated most of odontogenic infection streptococci or uh, staphylococci. So uh, usually we use antibiotics with a wide range. Cefazolini, ceftriaxone. Okay, so that's all. Thank you. See you on my classes.